Hello everyone. Welcome back to Biostube. I'm Mintesnot, and today we have the second set of 25 asthma questions, covering advanced emergency cases, pediatric and pregnancy scenarios, rare complications, and super hard questions. Before we begin, make sure to subscribe, like, hit the bell icon, share and drop a comment telling me your score from part 1. Grab a pen and paper, and let's continue. 26. A 10-year-old child comes to the ER with severe wheezing and accessory muscle use. Peak expiratory flow (PEF) is 55% of predicted. What does this indicate? A. Mild asthma attack. B. Moderate asthma attack. C. Severe asthma attack. D. Status asthmaticus. Answer. C. Severe asthma attack. PEF 50-79% of predicted indicates severe attack, less than 50% indicates life-threatening status asthmaticus. 27. A 35-year-old patient presents with cough, wheezing, and shortness of breath. Labs show elevated eosinophiles. What type of asthma is most likely? A. Neutrophilic asthma. B. Eosinophilic asthma. C. Exercise-induced asthma. D. Allergic bronchopulmonary aspergillosis. Answer. B. Eosinophilic asthma. Blood eosinophilia often correlates with allergic or eosinophilic asthma type. 28. A patient with asthma has a PEF of 40% predicted despite using a nebulizer in the ER. What is the immediate next step? A. Discharge home with oral inhaler. B. Administer oxygen, high-dose nebulized beta-2 agonist, and systemic corticosteroids. C. Only monitor at home. D. Give antihistamines. Answer. B. Administer oxygen, high-dose nebulized beta-2 agonist, and systemic corticosteroids. PEF less than 50% indicates life-threatening exacerbation requiring aggressive management. 29. A 28-year-old asthmatic patient develops severe bronchospasm after taking non-selective beta blocker for hypertension. What is the most appropriate management? A. Continue beta blocker. B. Stop beta blocker and administer nebulized beta-2 agonist. C. Only give antihistamines. D. Switch to LABA only. Answer. B. Stop beta blocker and administer nebulized beta-2 agonist. Beta blockers can precipitate severe asthma. Immediate bronchodilation is needed. 30. A child presents with exercise-induced cough and wheezing. Pre-exercise PEF is 400 L per minute, post-exercise PEF is 320 L per minute. What does this indicate? A. No asthma. B. Mild exercise-induced bronchoconstriction. C. Severe asthma. D. COPD. Answer. B. Mild exercise-induced bronchoconstriction. Greater than 10-15% drop in PEF after exercise indicates exercise-induced asthma. 31. A 50-year-old patient has persistent asthma symptoms despite maximal inhaled therapy. Total IgE is elevated. What additional treatment may be considered? A. Anti-IgE therapy omalizumab. B. Only increase LABA. C. Stop inhaled corticosteroid. D. Antihistamines alone. Answer. A. Anti-IgE therapy omalizumab. Biologic therapy targets severe allergic asthma unresponsive to standard inhalers. 32. A patient presents with nighttime awakenings due to asthma more than twice a week. Which step-up therapy is recommended? A. Increase inhaled corticosteroid dose. B. Only use short-acting inhaler. C. Stop medications. D. Use antihistamines only. Answer. A. Increase inhaled corticosteroid dose. Stepwise management requires adjusting controller therapy based on symptom frequency. 33. Which of the following lab findings is commonly elevated in allergic asthma? A. Neutrophils. B. Eosinophils. C. Platelets. D. Lymphocytes. Answer. B. Eosinophils. Eosinophilia is a marker of allergic inflammation in asthma patients. 34. A patient with asthma presents with sudden severe wheezing, hypoxia, SpO2 85%, and confusion. What is the next step? A. Give oral antihistamines. B. Immediate hospitalization, high-dose nebulized beta-2 agonist, oxygen, and systemic corticosteroids. C. Monitor at home. D. Only inhaled corticosteroids. Answer. B. Immediate hospitalization, high-dose nebulized beta-2 agonist, oxygen, and systemic corticosteroids. This is a life-threatening asthma exacerbation, status asthmaticus. 35. A 7-year-old patient with asthma is prescribed inhaled corticosteroid. How can side effects like oral thrush be minimized? A. Use a spacer and rinse mouth after inhalation. B. Stop the medication. C. Reduce inhaler frequency to once a week. D. Only give oral corticosteroid. Answer. A. Use a spacer and rinse mouth after inhalation. Proper technique reduces local side effects. 36. A pregnant woman in her third trimester has moderate persistent asthma. Which is the safest controller therapy? A. High-dose oral corticosteroids. B. Inhaled corticosteroids, budesonide. C. Long-acting beta-2 agonist alone. D. Antihistamines only. Answer. B. Inhaled corticosteroids, budesonide. Budesonide is preferred in pregnancy. LABAs must be combined with ICS if needed. 37. A child with asthma develops sudden cyanosis, confusion, and silent chest on auscultation. What does this indicate? A. Mild asthma attack. B. Severe attack, impending respiratory failure. C. Bronchitis. D. Pneumonia. Answer. B. Severe attack, impending respiratory failure. Silent chest is a life-threatening sign requiring immediate intensive care. 38. Which medication can interact with theophylline, increasing the risk of toxicity? A. Ciprofloxacin. B. Salbutamol. C. Fluticasone. D. Montelukast. Answer. A. Ciprofloxacin. Fluoroquinolone antibiotics can reduce theophylline metabolism, causing toxicity. 39. A patient with severe asthma has persistent hypoxemia despite high-flow oxygen. What additional therapy should be considered? A. Non-invasive ventilation (NIV) or intubation. B. Only increase inhaled corticosteroid. C. Oral antihistamine. D. Bed rest. Answer. A. Non-invasive ventilation (NIV) or intubation. Life-threatening exacerbation may require ventilatory support. 40. Which of the following is a rare complication of chronic severe asthma? A. Pulmonary hypertension. B. Hypothyroidism. C. Diabetes. D. Hyperlipidemia. Answer. A. Pulmonary hypertension. Chronic hypoxia and airway remodeling can lead to pulmonary hypertension. 41. A 12-year-old patient with asthma is prescribed a LABA without ICS and experiences worsening attacks. Why? A. LABA alone increases risk of severe exacerbation. B. LABA reduces inflammation. C. LABA cures asthma. D. ICS should never be used. Answer. A. LABA alone increases risk of severe exacerbation. LABAs must always be combined with ICS in persistent asthma. 42. A patient reports tremor, palpitations, and insomnia after using asthma inhaler. Which drug is the likely cause? A. Short-acting beta-2 agonist, salbutamol. B. Inhaled corticosteroid. C. Montelukast. D. Antihistamine. Answer. A. Short-acting beta-2 agonist, salbutamol. Beta-2 agonists can cause systemic side effects like tremor and tachycardia. 43. Which of the following is true about asthma management in children? A. Peak flow is used in all children less than 5 years. B. Viral infections are common triggers. C. Short-acting inhalers are never used. D. Oral corticosteroids are first line for mild asthma. Answer. B. Viral infections are common triggers. Viral respiratory infections often precipitate pediatric asthma exacerbations. 44. A patient with severe persistent asthma is unresponsive to high-dose ICS and LABA. What advanced therapy may be considered? A. Biologics, anti-IgE, anti-IL-5, anti-Illinois 4R. B. Only increase ICS dose. C. Stop medications. D. Use antihistamines only. Answer. A. Biologics, anti-IgE, anti-IL-5, anti-Illinois 4R. Biologic therapies target specific inflammatory pathways in severe asthma. 45. Which of the following strategies is most effective in preventing asthma exacerbations? A. Proper inhaler technique and adherence to controller therapy. B. Only using short-acting inhalers as needed. C. Avoiding all medications. D. Using antihistamines daily. Answer. A. Proper inhaler technique and adherence to controller therapy. Correct use of medications and consistent adherence is key to preventing attacks. 46. A 34-year-old patient with severe eosinophilic asthma is on high-dose ICS/LABA but still has frequent exacerbations. Blood eosinophiles are 600 cells per microliter. Which biologic therapy is most appropriate? A. Omalizumab, anti-IgE. B. Mepolizumab, anti-IL-5. C. Dupilumab, anti-Illinois 4R. D. Montelukast. Answer. B. Mepolizumab, anti-IL-5. High eosinophil count indicates Illinois 5-driven asthma. Anti-IL-5 therapy reduces exacerbations in eosinophilic asthma. 47. A 28-year-old asthmatic patient develops paradoxical bronchospasm immediately after using a new bronchodilator inhaler. Which drug class is most likely responsible? A. Short-acting beta-2 agonist. B. Anticholinergic, SAMA/LAMA. C. Inhaled corticosteroid. D. Leukotriene receptor antagonist. Answer. B. Anticholinergic, SAMA/LAMA. Rarely, inhaled anticholinergics can cause paradoxical bronchospasm. Always monitor initial doses. 48. A patient with severe asthma presents with fixed airway obstruction on spirometry, FEV1 FVC less than 70% despite optimal therapy. Which pathological process is most likely responsible? A. Airway remodeling, smooth muscle hypertrophy and fibrosis. B. Acute inflammation. C. Pulmonary embolism. D. Pleural effusion. Answer. A. Airway remodeling, smooth muscle hypertrophy and fibrosis. Chronic severe asthma can cause irreversible structural changes leading to fixed obstruction. 49. A patient on theophylline therapy presents with nausea, tremor, and arrhythmia. Serum theophylline level is 25 micrograms per milliliter. What is the best next step? A. Continue the same dose. B. Stop theophylline and provide supportive care. C. Increase dose gradually. D. Switch to LABA only. Answer. B. Stop theophylline and provide supportive care. Therapeutic range: 10 to 20 microgram per milliliter. Greater than 20 micrograms per milliliter indicates toxicity. Stop drug and monitor. 50. A patient with severe allergic asthma is unresponsive to anti-IgE therapy, omalizumab, and has elevated Illinois 5 levels. Which next-line therapy is most evidence-based? A. Dupilumab, anti-Illinois 4R. B. High-dose inhaled corticosteroid only. C. Oral antihistamines. D. Montelukast alone. Answer. A. Dupilumab, anti-Illinois 4R. Dupilumab targets Illinois 4, Illinois 13 pathways, effective in patients unresponsive to anti-IgE therapy with persistent eosinophilic inflammation. That's it for the second 25 asthma questions. How many did you get right? Comment below your score. I'm Mintesnot, and don't forget to subscribe, like, hit the bell icon and share to get more pharmacy and medical exam questions from Biostube. See you in the next video.